Hi, this is Elliot Fishman. Welcome to part 3, and this is going to be the final part, 3 of 3 of a talk on abdominal aorta and its branches, looking at some of the processes from aneurysms to dissections to vasculitis. We spoke a bunch about the renal artery last time. Let's just finish up on that. We spoke about aneurysms. We also need to comment on dissection. Most of the time I see renal artery dissection is extension from abdominal aortic dissection into the renal arteries. You can see it as a result of trauma. It's an unusual complication of fibromuscular dysplasia, an antiphospholipid antibody-associated disease. You can see it occasionally with Ehlers-Danlos, which gives aneurysms, as well as occasionally dissection, and it can be idiopathic. Here's a nice example of a focal dissection in the patient's right renal artery. I should also mention iatrogenic patients who've had catheterization of the renal artery can get focal dissections. We talk about renal artery thrombosis, thromboembolic disease, cardiac being most common as a source. Patients with endocarditis can also be due to renal artery insult from trauma or fibromuscular dysplasia, as well as hypercoagulability states like antiphospholipid syndrome and nephrotic syndrome. We talk about looking at the renal artery again, looking at perfusion, looking at both the renal artery itself, but also looking at the perfusion of the kidney. Sometimes the thing you recognize first is the perfusion changes, particularly their wedge shape, and then you look carefully at the renal artery, looking for aneurysms, dissections, narrowing, beating, and the like. Infarcts can be subtle, particularly early on. Also, it's easy to miss infarcts, as well as many things if you don't do IV contrast. It's also important to note that when it's an incidental finding, sometimes infection and infarction can look very similar. Here's a really nice example of perfusion changes and infarct in the right kidney, but you also see the thrombus in the patient's right renal artery. We also have some things that we just wrote a paper about, renal artery AVMs, abnormal communications between artery and veins, can be a congenital fistula, can be due to trauma, can be due to tumor. It's often a patient presenting with flank pain, and sometimes we have patients with hematuria. You're looking for a mass or a stone, and you see this complex series of vessels. Life-threatening hemorrhage occasionally can be a cause, or it can be related to these AV malformations. And again, CTA is particularly good for showing these and showing the complex anatomy. So it's rare, and again, it can be large, usually located near the hilum of the kidney, and interestingly is usually solitary. Maybe that's not a surprise, but it's more commonly right-sided. Clinical presentation most commonly that we see is hematuria, but hypertension, flank pain, and high cardiac output failure are all possibilities. Here's a nice example, axial view. Look at that large, what looks almost like an aneurysm, maybe with a dissection, but then when you start looking more carefully, you realize you're dealing with an AV malformation because you see the early draining vein. Actually, here the vein actually obscures the artery when you look at the axial images, but beautiful opacification, arterial phase of the aorta. And then look at the flow going straight into the renal vein, classic for an AV malformation. You can see it, you follow it down on the axials, but it's really when you go to the volume, whether coronal, but particularly the volume rendering. Here you see the MIP, the multiple lobulations, again shown on this image as well. The larger renal artery, look at the renal artery on the right compared to the renal artery on the left side. The large AV malformation seen on these MIP imaging, and the AV malformation, and look at the size of the right renal vein, which you can see very nicely, and the AV fistula on the right side, period. You also can see a little bit of the stenosis in the patient's SMA. Again, beautiful example of what is a classic AV malformation. Big renal artery, tortuous early venous filling, and a large renal vein. Here it is on the coronal views. As you get toward venous phase, you can see that it almost looks like lobulations, very nicely shown. The kidney function looks pretty normal. Contralateral kidney has a simple cyst. Beautiful AV malformation, right kidney. And again, in this article by Ayez Agahav talking about vessel vasculitis. That whole spectrum of things that can involve vessels, talking about classification based on vessel size, talking about the vessels that are involved, and renal artery. Again, we showed you stenosis, we showed you beating, we showed you aneurysms, we showed you dissection, we showed you AV malformations, and we also talk about vasculitis. I showed you an example of this before of polyarteritis nodosa, where you have multiple aneurysms. They're all tiny, like little beads in the renal arteries bilaterally, particularly within the kidney. Again, more common in men, a bit older, 5th to 7th decade. Renal involvement is common with up to an 80% incidence. Patients' proteinuria, hematuria, and hypertension are what's classically found. And again, polyarteritis nodosa is a necrotizing vasculitis. And again, just a really impressive type appearance. Patients are often ill. The first thought may not be vasculitis. There was a wonderful case a couple of years ago where Dave Hellman made an amazing diagnosis. Dave Hellman's one of the gurus of vasculitis at Hopkins. And just a patient who presented with a range of symptoms, hard to tell what was going on, but was able to make the diagnosis of PAN, vasculitis. So again, aneurysms are small and medium-sized vessels. You also see other problems in the kidneys, from infarcts to loss of cortical medullary differentiation, with the hallmark being a range of aneurysms in small and medium-sized vessels, but numerous aneurysms is going to be the key. And here I showed you this example before where it almost looks like stones. There's so many little densities in the kidney, but as you go to the venous phase, you see areas of decreased perfusion in the cortical medullary interface. And then when you go from that to the MIP imaging, look at all of those aneurysms. You see it here on the MIP imaging, multiple tiny aneurysms. There's also aneurysms in the splenic artery, aneurysms in the SMA, as well as very nicely showing you this with cinematic rendering. So again, making the point, PAN, classic renal involvement, but also multiple other vascular beds. So you need to look really careful. A combination of MIP imaging and volume rendering works very nicely. Here's just a few more examples showing you some of the SMA involvement, as well as multiple renal artery aneurysms as well. So again, the point I do make with vasculitis in general, or any vascular abnormality, FMD, or aneurysms, you need to look extra carefully at all the vessels. Yes, I know you do all the time, but I would go back vessel by vessel, look at the SMA, I see nothing. Celiac, I see nothing. Renal arteries, I see something. Splenic, I see nothing. Just go really in a very meticulous pattern, going through each of the vessels and saying yay or nay. Very, very important. Here's a second case of polyarteritis nodosa, prior coiling by the GDA. But you can see the patient has a dissection in the aorta. You also can see multiple tiny aneurysms involving branches of the SMA and branches of the celiac artery. And again, really nice example showing you the irregularity of the vessels and the multiple small aneurysms or pseudoaneurysms, particularly in the SMA. And here it is again on the volume rendering. So just another nice example. And again, the emphasis on the point, multiple small aneurysms or pseudoaneurysms, multiple vascular territories are where you're going to see things. Now, we spoke about this in our article about cinematic rendering and renal arteries. It's a nice article published literally a couple weeks ago in the fall of 2024. Also making the point that large vessel vasculitis like Takayasu's can also involve the renal arteries. It's not just FMD or polyarteritis nodosa, but other vasculitis. So the renal artery and the renal bed in general is a very good source or site of involvement by patients with vasculitis in general. We also talk about small vessel vasculitis, usually involve intraparenchymal arteries and capillaries and venules. Two types, ANCA-associated small vessel vasculitis and immune complex associated small vessel vasculitis. We see a lot of IG4 vasculitis these days. IG4 is interesting because we talk about IG4 related autoimmune pancreatitis. We talk about soft tissue thickening around the aorta. Here's a good example. Look at the patient's hepatic artery. It almost looks like encasement with pancreatic cancer, but the patient has no pancreatic mass. You see the soft tissue infiltration. That's a good example of vasculitis. You can see how the hepatic artery, compared to the splenic artery, it's really small. It's patent but narrowed more distally, but it's encased. And again, you think about tumor encasement. I think about pancreatic cancer all the time. So when I see the hepatic artery looking bad, I'm always thinking about pancreatic cancer. But here's a great example of the hepatic artery due to vasculitis. IG4 related disease, very nicely shown. The soft tissue. So when we see soft tissue infiltration these days, again, we always think about malignancy, but you need to think about vasculitis, particularly IG4 disease. And again, the hepatic artery involvement very nicely shown here. And here, the infiltration, the soft tissue, as well as the multiple areas of narrowing and their occlusion of branches of the hepatic artery. Here's a good example of thickening around the aorta due to IG4 disease. Things we think about, right? A retroperitoneal fibrosis, which can be drug-related. We think about lymphoma, particularly once it's been treated, when there's soft tissue thickening around the aorta and the branches. One of the things with IG4 disease, it extends down the aorta, down the common iliac arteries, and can be fairly extensive. The lumen of the aorta is decreased. The soft tissue infiltration, very nicely shown here. You can see the lumen of the aorta is decreased because of the involvement. There is calcification, which is a result of atherosclerotic disease, but the vasculitis, the IG4 disease, IG4 levels will often be high. Very nicely shown the narrowing, and this can persist. You can see it in vessels, not just the aorta, but the iliac vessels. Patients can present with lower extremity ischemia. You can see in this case, really nicely on the cinematic, the irregularity and the narrowing of the patient's aorta. And if not treated, this will expand to other vessels, including the iliac vessels. But again, here you can see there is some narrowing already in the patient's left common iliac proximally, and the patient was having some symptoms of claudication in the left lower extremity. Just a really nice look at this vasculitis. Now, the last couple of things I'll talk about, let's go back to the aorta proper. We talk about aortoenteric fistula, just to mention it. Usually communication between the aorta and the duodenum. Remember, when you have an aneurysm, the aorta sits on top or just below the duodenum. They're closely related. And so particularly patients who've had large aneurysms or therapy, repair, it's easy to get communication between the duodenum and the aneurysm. When you see air in the aneurysm sac, which you can see in this first case, you have to worry about an aortoenteric fistula. It's a life-threatening disorder. It's a surgical emergency. You can have spontaneous rupture of the aorta or erosion with bleeding into the duodenum. Classic triad: abdominal pain, massive GI hemorrhage, and pulsatile abdominal mass. We talk about the CT findings. We mentioned air within the aortic lumen or adjacent to the aorta. Direct extravasation from aorta to bowel is rare because patient will probably bleed to death before you scan them, though I've seen a couple of cases and a couple of patients managed to survive. We talk about wall thickening. So when I see an aneurysm and inflammation and wall thickening, I'm going to say I'm concerned about development in aortic enteric fistula. And so the patient's surgeon will be able to proactively do something before you develop that obvious fistula. Here's a nice example where the duodenum is here. You can see this large and expanding aneurysm. The patient had prior stent repair, but now the aneurysm and the patient's duodenum communicate. Aortoenteric fistulae. Here's the other example before, near where the graft is present, where the air is outside of the lumen of the vessel. And here's another example with lots of air showing you the grafts of the aortoenteric fistula. And an aortoduodenal fistula was found at the time of surgical repair. Here's a patient with stenting with back pain big aneurysm. You can see there's 2 stents, but this one looks like something's wrong with it. Maybe the stent broke. And you can see you're dealing with a fractured stent, and the patient had repair, and now the duodenum is sitting on top of it. And this patient now has an aortoenteric fistula. Just a really nice example, but the duodenum in close proximity to the aortic aneurysm. They're always in close proximity, but once they start touching and once there's inflammation and involvement, the fistula is a natural sequela. And again, intervention early will save the person's life. Here's a patient with back pain, rule out dissection. Patient had prior repair. Look at this aneurysm. Look at the break in the wall of the aneurysm. Look at all of this air surrounding the aneurysm. Again, you can see it here with this outpouching, an aortoenteric fistula with all of this air, this infection around the aortic bed, beautifully shown on these coronal views as well. And again, nicely shown here. And here it is on the cinematic rendering as well. So just a really, really nice example of that as well. And again, here's another view. So again, when you see air, you better be suspicious. It's a fistula till proven otherwise. So this was a mycotic aneurysm with fistula. Another patient with back pain, rule out dissection. Kidneys function okay. The aorta looks good. And we follow it down, and then the aorta is occluded. So this to me looks like thrombus. So the patient has aortic thrombus. Maybe the patient had an embolic phenomena. You follow it down, it goes for a long distance. There's a little bit of inflammation. That's a possibility. Here it is on the coronal 3D volume rendered views. Occlusion by the common iliac proximally with reconstitution by the femoral artery. We saw the thrombus. What's going on here? So to me, that's a very long thrombus. That would be my impression. The patient ended up having this thrombus be removed or trying to remove it, and the path came back that it was a sarcoma. So I like to end with this case just to make the point that vessels are always challenging. We talk about vasculitis, we talk about aneurysms, we talk about dissections, we talk about all sorts of processes. We talk about complications when we do repair, when we don't do repair. We talk about occlusion of vessels. We talk about embolic phenomena. But we also need to, every once in a while, think about the possibility of tumor in a vessel. This was an intravascular chondrosarcoma, kind of like looking at the chest, looking at the pulmonary arteries. Every filling defect, or 99.9% of filling defects, are pulmonary emboli. Every once in a while, you have a sarcoma of the pulmonary artery. It's larger, it's longer, and it doesn't get better with therapy. So again, tumors can occur within vessels, and this was a very, very unusual case. And just to make the point about thinking about vessels and thinking about back pain and distension, here's a patient with obvious endovascular leak in place. It's a really large leak, and you notice the left limb is really not opacified. It's not clear what's going on till you look very carefully at the patient's coronal views and you say, wow, look at this active extravasation, but these limbs are really far apart. Remember, they're always next to each other, those stents, and then you realize what happened here is the stent basically failed and dislodged, and kind of large active bleed. This patient actually survived. They were very lucky because the bleeding was contained within the aneurysm sac. But look at the failure of the patient's endovascular stent. Just a very, very impressive. And here it is on the 3D volume rendering. An impressive failure, but this patient indeed was very, very lucky, because look at the way that it kind of like with these days we talk about failures of grafting, of planes, of all sorts of technology. This is a good example of, I've never seen this before, where the actual graft dislodges and the patient has a large bleed. I do not know how long that graft was in place. It is a potential complication and was more common in the past than in the current state of grafting, so I don't know that. But just a really, really nice example of this graft failure. Really, really nice example. So Again, something to think about. So I've gone through many things. We talk about vascular mapping requires quality protocols to optimize acquisition. Post-processing techniques, including NPR and 3D mapping, are critical. We covered a wide range of pathologies that you can see in practice and the importance of CT in making the diagnosis and in managing these patients. And with that, I thank you for your attention and have a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.